I'm a mental health pharmacist and faculty at NEOMED. And our topic for today are the monoamine oxidase inhibitors. So we're gonna do a couple things in our quick didactic blitz. We're gonna look at the mechanism of action to see how they differ slightly, because we do have some variability within this class of MAOIs. We're going to identify the biggest obstacle for this class of medications, which is the interactions with other medications and foods, and then take a peek at the efficacy data. So recognizing that there are those obstacles, why might these be a class of medications we still want to use? So to start off with, the monoamine oxidase inhibitors were discovered actually as they were working on tuberculosis in tuberculosis patients. So there was one agent, iproniazid, that was used for TB, and they recognized that some of the patients that had been depressed actually were improving. That agent was removed from the market because of liver damage, but it spawned this class of medications for the treatment of depression. They were able to then further expand it to Parkinson's disease, and at the very end, I'll tell you where the other places are that they're looking. So it is an older agent, but this class of medications, really the use of them diminished pretty significantly as our tricyclic antidepressants came around, mainly because of the concerns related to the drug-drug interactions and the drug-food interactions, which we're going to delve into just a little bit more. First of all, just looking at how this works, because it helps set the stage for why we have concerns with some of those interactions. We have two monoamine oxidase enzymes, the A and the B. Both are located in the brain. The monoamine oxidase A enzyme is also located in the gut, which is going to play a really big role when we talk about those food interactions. They also process different neurotransmitters, so that monoamine oxidase A enzyme does process dopamine, norepinephrine, serotonin, and tyramine. It preferentially likes serotonin and norepinephrine are utilized most frequently and processed by the MAOI enzyme. Only at very high concentrations can they trip over to the monoamine oxidase B enzyme. So this enzyme mainly processes dopamine, tyramine, and then it processes a few other compounds. Phenylethylamine is one, and we'll talk about a few other toxins and products that this one may also interact with. But recognizing that there are the monoamine oxidase A enzyme really is the target for our treatment for depression. The monoamine oxidase B has been a target more for the treatment of Parkinson's disease, and that's not going to be the focus of today's presentation. So for our monoamine oxidase enzymes, I came across one study that was done about 6 or 7 years ago that identified there are quite a few healthcare professionals, so physicians, nurse practitioners, nurses, and pharmacists that aren't incredibly familiar with the monoamine oxidase inhibitors because we don't use them as frequently anymore. So I just wanted to serve as a reminder, these are the 4 agents we're really talking about. It was interesting. So it was less than 20%, less than 20% of the prescribers that were surveyed, and they were just surveyed from a national organization, had ever used any of these compounds. So most of them felt relatively uncomfortable. It was about 3/4 that felt uncomfortable using them, and mainly because of the interactions. But there's a couple different differences that I just want to point out for our non-selective irreversible. So these 3 agents, isocarboxazid, phenylamine, and the tranylcypromine, these 3 agents are non-selective. They bind to A and B enzymes, and they're irreversible. So it will take between 2 and 4 weeks for the body to create new monoamine oxidase enzymes. So it means when that medication's on board, those are essentially out of commission for that period of time. We have started to get other more selective agents, selegiline being the main one we're going to focus on here with this presentation. So it's more selective. It prefers the monoamine oxidase B enzyme, but it can inhibit the A enzyme as well. It also is irreversible, so once it attaches, the body has to wait to create more enzymes so that it has that activity. And that is transdermal, which will make a difference for us as we get into the interactions. So the primary reason these fell out of favor is because of the interactions, which there has been a big push to try to explore a little bit more what those interactions are, the severity of some of them, so that we're a little bit more, these aren't completely off the table for so many of our patients. So drug interactions are definitely a concern. Because these medications inhibit the monoamine oxidase enzymes, we can get higher concentrations of dopamine, norepinephrine, and serotonin. If we add other agents that further increase the concentrations of these neurotransmitters, we can potentially get really significant, possibly fatal effects from that. The two most highest profile are hypertensive crisis and serotonin syndrome. So this really is one of the reasons why we see those warnings on all of the medications for that washout period. We want to ensure that any other medication that enhances our dopamine or our norepinephrine or our serotonin, that we're allowing those to clear out before the MAOIs are on board, or vice versa, that our monoamine oxidase inhibitor is gone before we add a different agent. Obviously, fluoxetine is the one exception because of its extended half-life. So with this in mind, there is an extensive list of agents that really need to be used with caution that can interact with our monoamine oxidase inhibitors. Some of the more common tend to be agents that are going to assist with directly increasing the norepinephrine. So things like decongestants, so pseudoephedrine, phenylephrine. So if these are used short term, so not the extended release preparations, just short term, it's possible that they may be used safely in some of those patients. If they're going to be used chronically, so a patient's on a combination antihistamine and a decongestant because their allergies are just so out of control, that's likely going to be incredibly problematic for the patients. It's safest if they do have to use a decongestant to use the intranasal topical one for just that short period of time, so no more than 72 hours. So that's why it's got the little star there, was to remind me. So we do have some decongestants that we can use. Stimulants fall into that same category, so they can increase the concentrations of the norepinephrine that are available and could potentially cause some of those adverse effects. Now, with that in mind, there have been reports of combinations. So selegiline itself actually is metabolized it has some stimulant metabolites that we can pick up on. And on rare occasion, under supervised settings, they have used monoamine oxidase inhibitors and stimulants in really refractory depression. But that really needs to be done very carefully, making sure patient doesn't have other comorbid conditions and making sure that we can really monitor that appropriately and not put the patient at risk. And then other agents, including the serotonin norepinephrine reuptake inhibitors and our tricyclic antidepressants, also can increase that risk. On the serotonin syndrome side, our serotonergic agents, so your serotonin reuptake inhibitors are SNRIs, which we just mentioned, are tricyclics, and then other agents which also can increase, can somewhat inhibit the serotonin transporter. So things like dextromethorphan. So anyone who's on a monoamine oxidase inhibitor with the decongestant, the dextromethorphan, we really want to be careful what cough and cold products or allergy type products those patients are taking. And then there are concerns with some of our opioids. So things like meperidine, tramadol also could potentially increase the amount of serotonin that's available. There is some discussion about how much would be okay, but because that risk of serotonin syndrome, it could potentially be fatal, it's recommended that as best we can, we avoid this combination completely. So that means we got to pay much closer attention to not only the prescription, but the over-the-counter medications of patients using. And we need to pay attention and make sure the patients are educated about the food interactions. So this interaction is slightly different than the focus we had on our other neurotransmitters. And this is because tyramine can, so tyramine containing foods, which we all ingest at some point, can stimulate the release of norepinephrine. In healthy adults, they found that anywhere between 40 milligrams of tyramine to 400 milligrams of tyramine can be tolerated with very little change in blood pressure. Why? Because we have those monoamine oxidase A enzymes that are available in the gut that can break down that extra norepinephrine. So we don't have that. But if we're inhibiting all of the enzymes, so our class of 3, the isocarboxazid, the phenelzine, and the tranylcypromine, those are going to inhibit those gut enzymes. It means that we can't break down that extra norepinephrine, and it does increase the risk of developing a hypertensive crisis. So they've done a couple studies in patients who are using monoamine oxidase inhibitors, and in some cases it took as little as 10 milligrams of dietary tyramine to start increasing the blood pressure. So that didn't result in a hypertensive crisis, but it did start to demonstrate that it was a change from baseline. So enough of a change that they started to be concerned. Now the foods that would fall into this category of tyramine containing foods, things like aged cheeses, so gorgonzola, your blue cheese, dried, aged, smoked, cured meat, so pepperoni, summer sausage, the salami, those type of things. Other things that are processed that way, sauerkraut, kimchi, tofu and soy products, the fava beans, Marmite and other yeast extracts also contain tyramine, can increase the norepinephrine. And then tap, unpasteurized beer, and red wine, things like Chianti, also can contain increased tyramine. So not incredibly pervasive. There is the possibility that individuals go days without ingesting large quantities of these foods. But if they are on these medications, it would be something they would really need to be able to monitor and limit as much as possible. So if they're a big aged meat, sauerkraut with a draft beer, this is probably not going, and that's their preferred meal, this would probably not be a good match for those individuals. So doable. But should we? If it takes that much attention to both the medications as well as the foods, why would we want to do this? So there are a handful of reviews out there. I selected this meta-analysis because it included both inpatient and outpatient data. I recognize it is a little dated, but it really had the most comprehensive look. So in this meta-analysis, they evaluated 12 randomized controlled trials of isocarboxazid, 14 for phenelzine, and 7 for tranylcypromine. And in some of these trials, they also had active comparators. What they found was their response rate. So the response rate was defined as either a 50% or greater reduction in their Hamilton Depression Rating Score, or in some cases, they did use the CGI. So it was a CGI score of 1 or 2, so much improved or very much improved. And what they found was on the outpatient side, they were looking over 50% response rate in the outpatient, so significantly better than placebo across the board. On the inpatient side, they also were right around 50%. There were a couple differences. So for the isocarboxazid, even though the inpatient response rate was 56%, they didn't see as much of a difference in some of the populations. So they included patients that had refractory depression. The inpatient included some patients that had bipolar depression as well. So the isocarboxazid did have efficacy. It was found to be less effective than some of the tricyclic antidepressants that they used as active comparators, so things like imipramine or amitriptyline. So maybe a potential option there, but it looked to have better efficacy on the outpatient side. Outpatient trials did have longer duration than what they saw with the inpatient, so that may also play a role. The phenelzine, even though it looks like its response rate is significantly lower on the inpatient side, they, when they looked at the different categories of patients, in the patients that had atypical depression, where they used at least moderate to higher doses of phenelzine, so looking more 60 to 90 milligrams daily, they actually found that it was more effective than imipramine. At the lower doses, non-atypical depression, they did not see a difference, and it actually looked like the tricyclics were more beneficial in that particular group. So likely these are effective treatments for depression, but it's going to depend specifically on what it is that you're looking for. The tranylcypromine also had significant improvement on the inpatient side. This group actually had a couple trials that looked specifically at bipolar depression, and they did find some efficacy similar to the tricyclic antidepressants for inpatients that had bipolar depression. So effective, if we're thinking that, you know, we get about 2/3 of patients that respond to one of the first antidepressants that we select. In each of these cases, this was not first line, and yet still they had relatively robust responses to this drug treatment. So they're an effective group that we could potentially use as long as we can manage some of the complications that come along with it. Because I did not want to forget or leave out and neglect the selegiline. So this is data from 2 of the randomized controlled placebo-controlled trials of selegiline in adult patients. So one trial was fixed dose, so it was just the 6 milligram patch. Now that's the one that does not seem to interact with the gut monoamine oxidase A enzyme. So there's not a recommendation for those dietary restrictions at 6. If we have to go to 9 or 12, that's when we start to see that inhibition, where as you add more tyramine to the diet, they do see an increase in the blood pressure. Their primary endpoint was the mean change in the Hamilton Depression Rating Scale. So of the other trials, most of those were also similar sizes or slightly smaller, so they really didn't get above 100. In the fixed doses, they saw a significant decrease. So a least square mean change in the Hamilton Depression Rating Scale of about 9. So taking those patients to in the lower, essentially the lower teens, just above 10. In the flexible dose, where they could use 6, 9, or 12 milligrams per 24 hours, they also saw about that 10-point mean change. So not quite 50% reduction, but again, this was only over an 8-week time frame. Both significantly greater decrease compared to placebo, and actually helped get this patch approved for the treatment of major depression. Because it is effective, what about tolerability? So aside from the serotonin syndrome risk, as well as the hypertensive crisis risk, these agents are relatively well tolerated. So if we're increasing norepinephrine, dopamine, and serotonin, really not a surprise. We do see some anxiety initially. You can see gastrointestinal issues related to constipation, sleep changes. So often insomnia, although some drowsiness is reported, and some dry mouth. In that meta-analysis, there was not significantly more dropouts with MAOIs for tolerability reasons. There was significantly more dropouts in the tricyclic antidepressants. So overall, they could be tolerated relatively well. And they are making a resurgence. So there is much more interest in looking at this class of medications because of some discoveries and theories looking at their role in neuroprotection. So not only do the monoamine oxidase enzymes break down the neurotransmitters, as they break down other amines that are in the body, those can create radical oxygen species, so things like hydrogen peroxide, as well as other toxins that could potentially contribute to neurodegeneration in other disease states. Also, they're finding that when they block the monoamine oxidase enzymes, they're seeing an increase in the synthesis of other agents that are really beneficial for the neurons, including brain-derived neurotrophic factor. Now, this was done in animal studies, but they're starting to look at potentially using this class of medications in patients. It says dementia. I saw it in Alzheimer's, although there is a little bit of discrepancy where maybe antidepressants increase the risk of dementia, but they're also looking to use it for the prevention of dementia, because if they can prevent some of these oxidative species from being created, they could potentially prevent or slow down the progression of dementia and cognitive impairment. For heart failure, they found that monoamine oxidase, it's upregulated in patients who have heart failure. So they believe that it actually plays a role in the development of reactive oxygen species that attack the myocardium, so the heart tissue itself. So they're looking at potentially using this class of medications. There's most of the work's being done in animal studies, but they found significant improvement in patients who had depression with cardiovascular conditions, including heart failure, and they tended to do better with this class of medicines. So they're looking at it in that area as well. And then the last area, for a number of our inflammatory conditions, so multiple sclerosis, rheumatoid arthritis, Crohn's disease, and actually renal disease as a result of elevated IgA levels, there's a lot of tumor necrosis factor alpha. And with that, there tend to be a lot of monoamines that are floating around. When they reduce the activity of the monoamine oxidase, they actually see lowering of the TNF alpha levels. So they're postulating that they could potentially impact that inflammatory cascade by inhibiting this enzyme. So there's a lot of work and interest being done, not only with our existing agents, but with a number of newer agents that are a little bit more specific and maybe reversible inhibitors. So because they might make a resurgence, we thought it would be a good idea to do a refresher on this. So monoamine oxidase inhibitors are a potentially useful class of medications for the treatment of depression. They have some efficacy in anxiety disorders as well. It does require monitoring of not only their medication list, prescription and over-the-counter, but also education and adherence to a little bit more of a restricted diet because of the tyramine. With that, I will turn it back over.
All right.